Sinai Medical Center. He previously held positions as the Ramsey Crotan Professor of Pathology at Harvard Medical School, Chair of Pathology at the Brigham and Women's Hospital, and the Rourke Professor of Pathology at the University of Pennsylvania, and Chair of Pathology at Children's Hospital of Philadelphia. Dr. Golden received his BA from the University of California, San Diego, and his MD from the University of Pennsylvania. He trained in anatomic pathology and neuropathology at the Massachusetts General Hospital, followed by postdoctoral training in the Department of Genetics at Harvard Medical School. Dr. Golden's research has focused on understanding the developmental, molecular, and cellular basis of neurodevelopmental disorders. He has had a particular interest in cell migration and interneurons as they relate to epilepsy, intellectual disabilities, and autism spectrum disorder. He has also contributed to our understanding of human pathology in these and related areas. Dr. Golden served as president of the American Association of Neuropathologists, was president-elect for the Association of Pathology Chairs, and has chaired several NIH study sections. He also chaired the Board of Trustees for the Brigham and Women's Hospital Physicians Organization. I will now turn it over to Dr. Golden.
Thank you very much, Angelica. Can you see my screen?
Yes.
Okay, great. Well, it's great to be here and talk about this topic, which actually is one I've been interested in since I was actually an undergraduate and published my first paper on neural tube closure defects. So I've had a long-standing interest in this. And I think it's valuable to really be thinking about this because as neuropathologists, we don't often get a chance to see these kinds of cases very often. And so when you do, you really want to think through the various aspects of the pathology and the pathophysiology as it relates to the development of these very really deforming malformations. And with that, I want to just give the brief statement that some of the images that I'm going to be presenting are disturbing fetal images, and I'm doing it for illustrative purposes, but I just want to make it clear that I do understand and appreciate that some of these are very disturbing images. So I don't have any disclosures, as was previously noted. The learning objectives today, as also were previously stated, and just to kind of reiterate, I really want everyone today to have an appreciation for how neural tube closure happens during embryonic development. And it's actually quite a complex process, and it's different in different parts of the neural tube, possibly explaining why there's differences in the morphology and the pathology of neural tube closure defects. And so I'm going to explain that to you. I'll go through the mechanisms of neural tube defects and some of the genetic and environmental factors that are responsible for them. And then we're going to make sure that we walk through, and I'll actually do that at the very beginning, the different types of neural tube defects and how they might arise. So with that in mind, what are the definitions of neural tube closure defects? It's kind of simple to separate them into cranial and spinal. However, I want to really emphasize that this is a continuum, and that just like you see down second from the last in the spinal column, rachesthesis, which means a complete opening of the spinal cord, there is actually craniorachesthesis, which is the bottom one on the cranial side, which is involvement of the head and the entire spinal cord. So this is not one or the other, it's a spectrum. But I think for categorization and kind of descriptive opportunities, it's really simpler to think about it as cranial. And in the cranial, we have anencephaly. Anencephaly is merely absence of the brain. There's never truly absence of the brain, and I'll go through the histopathology of what that means. Encephalocele, that's where there is a defect, a bony defect that results in protrusion of part of the brain. There's other associated defects like craniomeningoceles, which is a defect in the cranium, but there's no protrusion of the brain. There's just protrusion of the meninges. And then some rare disorders, often accompanied by spinal neural tube defects in encephaly, which means there's a fusion of the posterior cervical vertebrae that gives the head a backward tilt. And then acalvaria, which I think really should not be, it's usually listed, and you'll read about it in textbooks. It's listed as one of the neural tube defects. It's really just the absence of a calvarium, but the brain is intact, and the rest of the surface epithelium is intact. And this is a completely different disorder. It's a different set of genetics, and I'm not going to talk about it further today. Now, when we talk about spinal defects of neural tube closure, we're mostly talking about lumbosacral, because that's the vast majority of them. They can occur in the thoracic or cervical regions, but those are highly unusual. And I think you'll gain an appreciation for that and why that is as we talk a little further today. But they do occur. But if you have it in the thoracic or in the cervical regions, it's almost always associated with a rachaschisis, or a complete opening of the neural tube. And again, I think you'll understand that by the time we finish today. Spina bifida occulta isn't a term used quite often. It means it's an occult spina bifida. Often it's recognized just by an unusual tuft of hair in the lumbosacral region. And there will be a bony defect, but no defect in the spinal cord itself. There's usually no neurologic sequelae. There may be a little bit of meninges protruding through, but unlike spina bifida cystica, where there's complete meninges coming through. Those are kind of more layman type terms. What's really appropriate terms would be myelomeningocele. That includes the meninges and the myelo, or the spinal cord. A myelocele is where the meninges are basically lost, and it's just an open placode that's the spinal cord itself that's exposed to the cerebral spinal fluid. A meningocele is the equivalent of a cranial meningocele, but in the spinal region, that involves a bony defect with a defect that with the meninges coming out into the into that bony defect and forming a cyst. And a tethered cord, which we're not going to talk about today, is kind of it's actually a number of different disorders, and I'm happy to discuss those at the end. But some of them fall into neural tube defects, but some of them do not fall into neural tube closure defects, and that's why I'm not going to talk about it today. Let's begin with a little bit of embryology. And I think this is important in terms of understanding where the neural tube comes from. The human egg is usually fertilized in the fallopian tube about 2 days after it's been released, a day and a half to 2 days after it's been released from the ovary and collected into the fimbria and then directed into the fallopian tube. It continues to grow, becoming a morula, then a blastocyst, and then an implanting blastocyst. The numbers you have of embryonic day 2.5, 3.5, 4.5 for that are all mouse, but they're actually not too different from the human, because if you go to the bottom left in the implantation, that implanting blastocyst will implant in the human around 6.5 to 7 days. So it's only about a day and a half off of when it's actually occurring in the mouse. And as that blastocyst implants, you start seeing that brown area, which is the area that is going to become the placenta. That's the embryonic part of the placenta as opposed to the maternal. So that's the fetal side of the placenta. And the green at the bottom will become the definitive embryo itself. And you can start seeing the evolution of the formation of a cup. And that cup, as I'm going to show you on the next slide, will actually evolve into the neural tube by induction that I'm not going to really talk about today, from the node, from the anterior neuroectoderm, and also from that primitive streak coming out of the adjacency, that primitive streak in purple, the adjacency of the fetal, what will be placenta or extraembryonic ectoderm, along with the definitive ectoderm that'll become the embryo. Those purple cells become the primitive streak. They're induced by the adjacency of that brown and green tissue, and that defines the early primitive streak that will actually become the mesoderm of the embryo. So that's what's happening in the embryo. Here it is, again, colorized. And what you see on the left is a cup. And the blue in this cup is going to become the surface ectoderm, which will become the entire nervous system, as well as all of your skin, so the integumentary system. The primitive streak is underneath that. You can see it on the left side there, labeled down at the bottom, just below the node. That's where your mesoderm is getting derived from, and you can see that in red coming in on the next image to the right. And what happens is that through these inductive forces that are at the node and at the adjacency of these extraembryonic ectoderm and the embryonic ectoderm, you get a structure that gets defined as anterior posterior, and from that lateral as well. And then what happens is that the embryo goes through what's called convergent extension. What that means is that the lateral aspects of the embryo are going to converge on each other, and it's going to extend in the anterior posterior domain. And this convergent extension actually occurs, and you can kind of see where it would be happening in that very first image at the top, is that the embryo converges in, that'll form the neural folds. I'm going to talk about those in the next slide. And as it's converging, it's extending out. And so now you have a clear anterior posterior axis. And as that's forming, and by the way, that is dependent, highly dependent on something called PCP, or planar cell polarity. And this is where there's changes in the shape of the cell. And the reason I'm saying all this is that we know there are mutations in planar cell polarity function that result in neural tube defects. And I'm going to go through that a little bit later as well. Now, what happens as that convergent extension is happening is that you have to develop neural folds. And those neural folds, which you can see, actually, can you see my pointer if I move this on here? Angelica,
yes,
can you see a pointer?
Yes.
You can. Okay.
Yeah.
So here's it goes from this flat surface ectoderm. As it converges in, you get these folds forming. And underlying these folds are actually the somatic mesoderm. The notochord is in the midline, but the somatic mesoderm is helping build up those folds. And it's a combination of the building up by somatic mesoderm, this convergence, which kind of pushes the cells together. And then, as I'm going to show you on the next slide, changes in shape in those cells that result in the tube rolling up, and it's actually going to have to fold at specific sites to actually lead to neural tube closure. And it's dependent on signaling from that notochord, which is predominantly producing sonic hedgehog. We're going to talk about that in a minute, as well as the interface between what is being defined now as the surface ectoderm, which you can see out here in orange, and the neural ectoderm. The boundary of those two is where neural crests come from, but the surface ectoderm is forming BMPs, bone morphogenetic proteins. And it's a combination of the BMPs and the sonic hedgehog, which also play a role in that folding of the neural tube. So these are scanning electron micrographs. This is way back from when I was an undergrad. What you can see here is the embryo. This is a mouse embryo. You can see that convergent extension, the convergence bringing this together here, extending along. You can imagine this having been a cup. So you can see where this would be one side of the cup, goes down into the base of the cup. This is where the notochord would be. And coming up the other side is the back end of that cup. And neural tube closure begins right here at the middle, the midpoint of this, which you can see here, it's closed and it's actually zippering up in both directions. And so that midpoint where it starts zippering up is kind of at the bottom end of the rhombencephalon, or the kind of the cervical cervical spinal cord medullary junction. So the junction of the spinal cord and the midbrain, that's actually the first site of neural tube closure. And then it starts zippering in both directions, basically closing that neural tube. But it turns out that's not how it closes the entire neural tube. If you actually take this embryo and turn it around and look at the front, you'll see that, and now we're looking at the face. So this is the telencephalon, this is the telencephalon, this would be the diencephalon right behind it, or what will become the thalamus. This down here is actually the heart. So the heart is already in place, it's starting to beat. And what you see is that there's another site of closure in the border right between the telencephalon and the diencephalon. And that then also starts zippering up in both directions. And there's actually another site, at least in most mice, and it's questioned whether it's in humans. Some say yes, some say no. But there's another closure that begins right in the stomadeum. The stomadeum is the area that's going to become the mouth. And right at the base of the mouth, which would basically be at the back of your palate, it starts closing up, and you're going to see this is the anterior neuropore, the end of the closure that'll be happening. The heart's been removed. You can see one of the brachial arches. You can see the other brachial arch on this side, and these are coming together and will fuse to form this being the upper jaw, the mandible. And when you have defects in that, you actually get a cleft lip, and you can get lateral clefts into the face because they don't fuse with the neural crests that are coming from over the top of the head. So you can see all of this embryology as you look at this in close detail. So how does the neural tube close? Well, as I've already alluded to, it actually closes in different ways in different places. If you look high up at kind of that midbrain hindbrain junction, what you see is that sonic hedgehog induces a midline fold. And so that midline fold is responsible for the cells change shape. Again, I'm going to show you this in just a slide or two. They'll change shape right on the midline, where it becomes what's known as the floor plate. They become wedge shaped. As they become wedge shaped, they basically, the narrow top and the long base forces that to fold. And that on top of that convergent extension, which is very prominent in that region that I showed you at the beginning of neural tube closure, results in pushing these large neural folds together, and they actually end up coming together and fusing at the dorsal midline. But in the case of, as you go lower down the embryo into the tail region, into the trunk and lumbar region, there's actually two sites of folding. Sonic hedgehog here, which actually represses this what's called dorsolateral fold, which is depicted in red. So sonic hedgehog induces this midline one. It actually represses this lateral one, and that's also repressed by BMPs. But what happens, and you can see that over here, that everything's repressed by BMPs. Sonic suppresses something called noggin, which I'll get to in 1 second. But as you go down the neural tube lower and lower, what happens is you get higher and higher amounts of a protein called noggin that actually suppresses BMP itself. And because you get higher and higher levels, it outstrips the suppression that sonic hedgehog has. And so noggin then ends up being able to suppress BMPs. There's not enough sonic to suppress noggin, and you get activation of this intrinsic dorsolateral fold in the neural tube. And that fold is important at the lower spine levels until you get to the coccyx, the very lowest, where there's secondary neurulation. And there's actually no sonic hedgehog anymore. And there's only BMPs that usually repress this, but you have high levels of noggin. And so you only get this dorsolateral fold. So what does that look like if you look at, before I get there, sorry. So what I've shared with you is that there's a midline fold, there's a dorsolateral fold, and then the tissues come together on the dorsal midline. And mesoderm pushes up. I mentioned the somatic mesoderm, which pushes up, which also participates in the closure. And there's actually a lot of mesodermal defects when you have neural tube closure defects. We know that. We see essentially with all neural tube closure defects, either spine or cranial defects of the mesoderm. That's in part due to the changes in the shape of the cells at either the the ventral midline, the floor plate, which I mentioned. There's a change in shape of the cells. It's due to actin myosin, a basically contractile structure that brings the apex of the cell together, but not at the base. That is actually mediated through things like MARCs, the MARCs proteins, which are actually known to be mutated in patients with neural tube closure defects, as well as some of the myosin defects. So that's on the actin side. On the myosin side, things like SHRM3 are involved in the in that activity, and that's also been mutated. Mutations have been identified, as I'll mention later, in patients with neural tube closure defects. So there's a change in the cell shape. There's an increase in mesoderm, and another process that has always been known to be important for the fusion. So how do two epithelial layers come together and fuse? Well, what happens is that not only do they send some interdigitating processes out for the cells to come together, but there's also important cell death, so that there's a breakdown in that surface epithelium such that it allows for what processes exist to actually interdigitate and form a single epithelium. So we know programmed cell death is important for the final fusion. And when you block that cell death, you actually get neural tube closure defects. But we also, very recent work, it just came out a month ago, which I think is very interesting, has also alluded to this idea that cell death results in a dimpling, kind of a pulling down of the epithelium at this dorsolateral point, probably mediated through that repression of BMP and through noggin, that results in also a tethering at that point and actually a change in the shape of the neural tube that allows for that neural tube closure to occur. So what does that look like in a real embryo? So here you can, again, going back to these scanning electron micrographs, you can see here is the flat neuroepithelium. During convergent extension, you get the bringing together of these folds, the buildup of the somatic mesoderm underneath that, and these come together. And high up, where that primarily occurs, you can see the mesoderm being built up on both sides. You can see the neural folds, and you don't see a dorsolateral hinge point. You only see that midline hinge point, and that folds things together. If you go down a little bit lower, you see both a midline hinge point and the dorsolateral hinge points. And if you go down low enough, you actually only see the lateral hinge points. These lines are actually, I apologize, they're at the wrong level. So that's what it actually looks like. And as I already described, in the head region, it's a completely different set of folding that occurs due to, and I'm not going to go through these details because they're actually much less understood. The folds of the head are really poorly understood. They're really described, but it seems to be that cranial neural crest cells, which come up over the cranium from the rhombencephalic region or the hindbrain region, are important for driving those folds together, which first start out kind of extra folded outward, and then they come together in uncertain ways. And then I'll finally say that in some regions, like the what would overlie the fourth ventricle, closure actually occurs not by the neural tubes ever coming together, but here you can see them wide open. This is a membrane. Hopefully you can see there's a little membrane that's coming up over this. There's just a little bit of an opening. And finally, you can see this rhomboid shape of the fourth ventricle here. This is the rhombic lip right here, which is going to actually grow down and form the cerebellum. And as it grows down, it covers the fourth ventricle. leaving the foramen of Majandi in the midline and the two lateral foramina of Luschka. And so through that whole process of the cerebellum growing back and over the fourth ventricle, becoming the roof of the fourth ventricle, you actually get the full brain covering the surface, but the actual neural tubes have never come together. They just have this membrane that covers that fourth ventricle. And here you can see it in a cross section. So it's a cross section of a mouse embryo. You can see the neuroepithelium all the way around, but in the hindbrain area, there's just a thin membrane that is not neuroepithelium, surface ectoderm that's covered it. And from that rhombic lip, which is right here, actually it's right here, is going to grow back over it, forming the cerebellum, covering the fourth ventricle, and that cerebellum becoming the roof of the fourth ventricle. So what I've tried to show you in terms of understanding neural tube closure is that it begins here in this kind of hindbrain and spinal cord level. It zips up in both directions. As it goes down the spinal cord and you get closer to the notochord, the mechanism of closure actually changes. So it goes from being a predominantly sonic hedgehog driven midline hinge point closing it to being dependent on both a midline hinge point and a dorsal lateral hinge point, to in the very bottom being a dorsal lateral hinge point only. That's for the spinal cord, but in the head, you see a second type of closure occurring. It zips up in both regions. I'm not going to go through calling these 2A and 2B, but that's what they've been defined before. A third one in that very rostral part right up against the stomadeum. And so you've got this complex set of closures that give you the different morphology of the neural tube closure defects that we're going to soon be looking at. So as I mentioned, these pictures are not pleasant to look at, but I hope they'll be illustrative as we go through this. So on the far left is an absence of closure in the head region in a mouse embryo by scanning electron micrograph. So the head should all be closed by this stage. You can see that it's wide open. And this is what gives you anencephaly. So here you can see this very hyperemic tissue all over the cranium. If you went down the spine might actually look okay. The reason you get this hyperemic tissue is that it's actually interaction of the cerebral spinal fluid with the open neural epithelium. And that results in a degradation, a degrading of that, forming this hyperemic tissue. And I'm going to show you histology of that in just a minute or so. But this is classic anencephaly, where there's an absence of just the brain. The spinal cord, you can see the back is intact completely. And kids that have anencephaly have a very characteristic look with these what look almost proptotic large eyes, a triangular face. And this has actually been described as a frog-like facies. And I want to address that for a minute, because there's actually an interesting historical component to that. Because Geoffrey St. Hilliard, who was a famous medical anthropologist, uncovered some very interesting information when looking at into some of the writings on papyrus in ancient Egyptian times. And they described kids that look like frogs being born to moms. And this is where the idea of what happens during pregnancy will actually result in in what the fetus looks like, the so-called impressionism. And it was also known in ancient Egyptian times that if you had a fever, you were supposed to hold a frog to help the fever go away. But if you had a fever while you were pregnant and held a frog, you might have a child that has a frog-like look to that child. And in fact, we know that hyperthermia, maternal hyperthermia, is a cause of anencephaly and neural tube defects. So Geoffrey St. Hilliard, before he even knew it, he wrote about this over a century ago, recognized the association of holding this frog, fevers, and neural tube defects, or these children that were born with a frog-like facies. And we believe this is exactly what they were looking at. And we actually know that this is now there's a biologic underpinning of that, which is maternal hyperthermia. Well, cranial rachesthesis, as I mentioned, this comes together. This is where the entire head or the cranium, as well as essentially the entire spinal cord, is open, and complete destruction, again, with this hyperemic tissue all the way down. The only part that's closed is what's called secondary neurulation, where the neural tube doesn't have to actually close. It just extends down underneath the skin. But when you start looking at different neural tube closure defects, it turns out that they're not all the same. So this is one that the brain was mostly enclosed. Some might call this an encephalocele, although there was a lot of open placode that led to destruction of this brain. But you can see that the head was mostly closed over the anterior part. So basically the closure work, the neural tube closure worked all the way down the spine. In the front where it started, there's just a defect in the closures coming together in the back. A very specific type of closure. By the way, this involves brain tissue, but not cerebellar tissue. And I like to, at least at this point, distinguish it from something called Chiari 3. So remember, there's 3 types of Chiaris. I'm going to show you the other 2 later towards the end of the talk. But this is a Chiari 3, a very rare malformation that is actually an encephalocele involving the very occipital bones and involving the cerebellum and posterior fossa elements. I've actually never seen a case in vivo myself, so I don't have any gross pictures of it. This is the best I have from a case that was sent to me, just the images from South America. But then we get to the spinal defects, and here you can see a lumbar, kind of mid to lower lumbar one with an open placode. This would be a meningocele. And what I really want to point out is histologically, this is the central canal. You can actually even see, hopefully, a little bit of epithelium, and it's completely, you can see the epithelium going out the sides. The neural folds never came together. There was never a central canal that was formed. So this is a open neural tube where the placode is just extending out into the adjacent tissues. Here's another one. This is a low one. So this you can see is really sacral. And you can see that part of the neural tube, the spinal cord itself is extending out into this bony defect. Here you can see the bone should be closed along posterior. You can see the central canal. And this is an example of a myelomeningocele, because the meninges here, which you can see right here, are going out and around. And so you're forming an actual sac of this case. And if the spinal cord hadn't come out and the meninges closed this off where the spine just remained here, that would be either a meningocele or it could be what would be a spina bifida occulta. Now, I've alluded to this a number of times, but the epithelium, the neuroepithelium that you see, if you look at either the spine or in the cranial region, you'll see surface squamous epithelium coming right up to neuroepithelium. And the neuroepithelium will be very disorganized. And what happens to it as it degrades, as it interacts with the cerebral spinal fluid, you can see that it becomes very vascular. And this is in the cranial region known as area cerebrovasculosa, because it's brain tissue with blood vessels. So area cerebrovasculosa, and that's what you see. Now, interestingly, if you have a fetus, an early fetus that has a neural tube defect, by the way, I forgot to mention, neural tube closure in the human begins at about 18 to 19 days. Remember I said implantation starts at about 7 days? Well, that convergent extension and the buildup of the folds and the beginning of the neural tube process takes about another week, about 10 days actually. And at about 18 to 19 days, the neural tube starts actually fusing and closing. Neural tube closure is complete in the human at about 28 to 29 days gestation, way before a mom even knows that she's pregnant. if you get a fetus with a neural tube closure defect, the neural tube has failed to close, let's say at about 5 weeks, 35 days, or 7 weeks, 49 days in that period, what you actually see is something called exencephaly. The brain is actually relatively normally organized and growing out. It's outside the body or the brain, the calvarium itself. It's kind of expanding out. It's actually looks too big, but it hasn't started to degrade yet. It's only with time. And so when you get fetuses, typically at the 20 weeks, 22 weeks, that time, the brain is undergoing this degeneration and you're getting this hypervascularity or area cerebrovasculosa. Now, if it's in the spinal cord, you see the exact same thing. And actually this top image here, these two are from the brain region, so area cerebrovasculosa. This is actually from the spine region, and this is area medullovasculosa. It's the exact same thing. It's just the medulla or from the spinal cord. So it's a semantic thing. And so what I've hopefully described to you here is and this is just in cartoon form, here the normal closed neural tube. You can have just the meninges involved, that's the meningocele, a meninges and the spinal cord itself, the meningomyelocele. And then if it's an open defect where the meninges have basically been lost and you just have the open defect of the spinal cord to it, it's called a myelocele. And in the head region, and again, that's almost always in the lumbosacral region, because you can imagine if you fail to get that early induction of the spinal, of neural tube closure in that cervical medullary junction, then you don't get any of that zippering up and you get a rachaschisis. So it's unusual. It does happen on rare occasions. We actually don't understand the pathogenesis to have a high neural tube closure defect in the spine, but usually it's either rachaschisis or in the lower part where these other mechanisms of neural tube closure play a role. And in the head region, we note that it can be the entire head, as I showed you before, but it can just be anterior. So this is an anterior encephalocele due to defects in these anterior closures. And you can have brain or just meninges in that. Or it can be just posterior in this hindbrain region, where as long as it's cerebral tissue, it's called an encephalocele. If it involves the cerebellar and posterior fossa elements, then it's a Chiari-3 malformation. All right, let's turn to what are the factors, what are the causes of neural tube defects? And let me just first state that we know very few causes. There's a number of different animal models. There's a small number of single gene defects, but it is very rare, less than 1% that we really understand. So what really is playing a role in neural tube closure defects is the fact that it seems to be an interaction between the environment and genes. So a genetic predisposition with an environmental impact. So what are those kind of things that modify your risk for a neural tube defect? And some of them you maybe know, things like maternal diabetes. This is kind of interesting. Moms that have diabetes, particularly when it's not well controlled during pregnancy, have somewhere between a 2 and 10-fold increased risk of having a neural tube closure defect. That may be due to the metabolic changes that result in changes in your folate levels, and we're going to talk about that in a minute too. Maternal obesity, also a slight, lower than maternal diabetes, but a slight increase in having a child with a neural tube closure defect. Here you can see it's about a 1.5 to 3.5-fold increased risk. Maternal hyperthermia, I've already mentioned, it's at least a 2-fold increase. So, moms stay out of saunas and be careful of fevers and managing fevers. There are a number of drugs that actually increase the risk. The best known is valproic acid. It's used for control of seizures. It's an anti-epileptic. And when valproic acid is given there's about a 10-fold increase in your risk of having a child with a neural tube closure defect. And so it's important that if a family is interested in getting pregnant and the mom is epileptic, that she change her anti-epileptic regimen. And then there's a whole variety of maternal nutritional factors. And the one that's probably gained the best data and information is folic acid. So we're going to talk about that. And actually, in the interest of time, I'm going to skip this. So over a number of years, well, this actually first began in the 1970s when a couple investigators found that moms that had children with neural tube closure defects had deficits in some of the vitamin Bs, including folic acid. And subsequent to that, there's been some large epidemiologic studies. There's actually been a massive international campaign to introduce folate into the diet. And that introduction of folate into the diet has had a dramatic change in the incidence of neural tube closure defects. But it hasn't had a universal change. What it's done is, if you look at neural tube closure defects before there was the addition of folate into diets at a population level, there was about a 2 to 5-fold predominance of females with a neural tube closure defect. And that predominance in females was more for anterior ones, so cranial ones, as opposed to spinal ones. With the introduction of folate into diets, what has happened is there's basically an equalization of males and females. So it has predominantly advantaged the female fetuses so that they don't have neural tube defects at a higher rate than males. And it's also eliminated the cranial ones. So now you're seeing mostly spinal neural tube defects. And I will tell you right now, I'm not going to be able to answer why for either of those. We really don't know the answer to it. There's been some postulates, but the real answer is we don't know. So why folate and why neural tube closure defects? And so I'm going to be very simplistic in the biochemistry here, but folate comes in either as folic acid or through dietary folates, and those dietary folates get converted into 5-methyl tetrahydrofolate. I'm in the upper left of your the left-hand diagram, upper corner, and that's converted by methylene tetrahydrofolate reductase, which is the MTHFR. And I mention that because there's some very well-defined variants, single nucleotide variants in MTHFR, particularly MTHFR1, that put individuals at a much higher risk. Remember, folate doesn't correct everything. There are certain populations that have a genetic risk that when combined with folate deficiencies have a much higher risk of neural tube closure defects. So this is, now you're seeing this gene environment interaction really playing out. So what does this whole pathway do? Well, if you follow that down through the production of methionine, you then activate down at the bottom, in the left diagram, in the bottom right, DNMT, that's DNA methyltransferase. The methionine becomes a methyl transfer group. So it transfers methyls onto different things, particularly histones, which you can see in the bottom, which leads to transcriptional regulation changes. And it's thought that this methyl transfer defect, again, I'm getting into black box area here, disrupts epigenetic phenomenon, the histones, that result in defects in neural tube closure. Again,
hey, Dr. Golden, sorry to interrupt. Just wanted to give you a time update. We're at 12:46.
Ooh, okay. I'm going to go faster. Sorry. Yes.
No problem.
So, yeah, no, thank you for letting me know. On the right side, what you can see is the DMNT at the top, the DHFR, the MTHFR, all of those in there in the purple. Those are genetic risk factors. They affect methyl substrates like the histones, as well as the production of pyrimidines and purines. Again, in green, you can see those. And all of those are important for the for proliferation and neural tube closure defects. There's also growing evidence that the mitochondrial folate pathway through formate is involved in this as well. And I'm not going to cover that today. Just to get at the genetic defects, we now know there's coding defects in a variety of genes, including ones in the PCP pathway. This is the polar cell polarity pathway genes, VANGL1, VANGL2, PRICKLE1, FUZ, all of these genes. There's defects in sonic hedgehog, particularly GLE3 and some of the other activator pathways, like dispatch1. And there's chromosomal aneuploidy defects. Again, I want to point out that these are not often single gene. There are a couple single gene defects like PAX3 and SHROOM3, which I mentioned before, that are involved. But most of these defects are thought to all not be by themselves sufficient for a neural tube closure defect, but actually give you that predilection that when you have the environmental factors, whether it's folate or whether it's diabetes or drugs, put you at high risk for having a neural tube closure defect. And that's really what the main point I want to get across today. And this is just a very nice diagram. If anyone wants to go to this paper, I think I left it as one of the references by Joe Gleason's group to show the kind of idea of multiple gene effects. That's the multiple genes like in one are not sufficient by themselves. And even a couple gene defects with an environmental factor like folate, let's say, is not enough to reach a threshold. But as you get higher up with more gene defects or significant gene defects with folate deficiency, you can get to mild and severe neural tube closure defects. So let me end by talking about some things that come along with the common neural tube closure defects. That is the lumbosacral myelomeningocele. And what you can see here is a child that has a lumbosacral myelomeningocele and has a very enlarged head. This is hydrocephalus. But when you get, particularly if, now we see sometimes fragmented fetuses, we're asked, one of the things you can look for is something called Leukenschädel. This is a child I saw. Leukenschädel is where there's these bony defects that occur across the calvarium. And you can see this in embryos very nicely. And so there's these things where the bones are thinned out and you get so-called Leukenschädel, very characteristic of lumbosacral myelomeningocele. Not absolutely specific. You can see it with some other hydrocephalus, but it really, if you see it, you should look for some type of a myelomeningocele. Here, I just want to point out you can see that in a Chiari-2, which usually comes along with a lumbosacral myelomeningocele in most cases, greater than 90%, it's the vermis, the midline vermis that comes down over the spinal cord. This is vermis here. And you can see that in these images that I've dissected out. This tongue of the cerebellum is actually the midline vermis, not the lateral nodulus. Sorry, the flocculus. This is the midline. And you can see you can actually lift it off in the spinal cord here, separating those two. And that's in contrast to the type 1 Chiari, which is where there's a protrusion of cerebellum below the foramen magnum, but it's the lateral flocculus that comes down and the tonsils that come down. This is not the midline vermis, which you can see entirely intact here. The spine, I've already gone through this. Here you can see, sorry, let me go back one. Here you can see the open spinal defect of a neural plate that's open. But as we go down, here you can see an open bony defect. Here a spinal cord, and you can see it's got two central canals. This is diastomatomyelia, another defect. Sometimes you have diplomyelia, two spinal cords, usually with a pretty prominent structure, fibrotic septae between the two spinal cords. Here you can see at closer magnification the diastematomyelia with the 2 central canals. You actually get 4 sets of motor neurons, and you can see some of those larger motor neurons here, and they'd be out laterally to each of these central canals too. So you get 4 sets. Hydromyelia and syringomyelia, you can tell this is hydromyelia as opposed to syringomyelia. You can see this, the epithelium of the neuroepithelium of the central canal all the way around. And then finally, the asymmetric crossing of the descending corticospinal tracts. Here you can see a large ascending anterior uncrossed, a small on the opposite side, and then a very large crossed and a smaller crossed here. So you can have asymmetries in the spinal cord, and these can all accompany these neural tube closure defects. So I'm going to end there. I went a few minutes longer than I thought. I'm going to stop sharing my screen. I hope I've given you some indication of, let's see. I hope that what I've done today has given you both an understanding of how we define the different or describe the different types of neural tube closures, some idea of what neural tube closure, how it actually happens, how it's different in different parts of the nervous system, and some of the mechanisms for neural tube closure defects. So with that.
Yes, thank you, Dr. Golden. That was awesome. So at this time, we'll move into Q&A. You can submit your questions via the chat box or unmute to ask a question. When submitting a question via the chat, please ensure the message is to everyone so that everyone can see it. And to unmute, select the microphone in the left lower corner. And once you've asked your question, please remute to avoid background noise. And I don't know if you can see, there is a question already in the chat box. Can you see that, Dr. Golden?
I don't. I see. Thank you for joining us today for the AANP teaching round.
So I'm going to go ahead and read it. There's a question from Mark Cohen. Jeff, what I always referred to as myelomeningocele is here classified as myeloschisis, which on reflection does make sense. Is this the terminology that we should be using? And he has a link, but
yeah,
I'm not sure.
Yeah, Mark, it's a really confusing area because it's used different. The terminology is actually used different in the radiology literature, in the neurology literature, and in the neuropathology literature. And no one is agreed on a single literature or a single way of describing it, which makes it really hard. Being kind of a purist in this space, my preference is, but I'm in no way trying to say this is the way everybody should do it, but my approach and the way I've always done it is what's included in the defect. If the meninges is there, you include that. If the spinal cord is there, then it's a myelomeningocele. If the meninges are completely gone and it's just the spinal cord, then it's a myelocele or a myeloschisis. And so I think I prefer to do it based on what the anatomic features are. That's my recommendation. But I would not fault anyone for doing it differently because, you know, your radiology may do it differently and you may want to make sure that your report corresponds with the radiology. There's all kinds of ways to think about it. And I think it's important to really communicate what the meanings of all of it are with your clinical teams.
Okay, and then I have another question from Veena Rajaram. Thank you for a wonderful talk. Can you have an arachnoid cyst in the calvarium as a form of neural tube defect?
So arachnoid cysts are kind of interesting because there's arachnoid cysts that can occur and deform the brain. The posterior fossa one is a great example of that, where a lot of people think it's a Dandy Walker malformation, but it's actually exterior to the cerebellum, just pushing the whole cerebellum up, and it deforms. You know, part of the Dandy Walker is an expansion of the posterior fossa, and you can get that with an arachnoid cyst. You can also get arachnoid cysts that are rests that deform the bone, and those are often off the midline. And because they're usually off the midline, I don't think of them necessarily as neural tube closure defects. So arachnoid cysts themselves, I think, are probably rests of the arachnoid that are not part of, not in the spectrum of a neural tube closure defect. So that's how I really want to see all the meninges in there, beyond just the arachnoid and the arachnoid cyst. And again, because I so often see those off the midline, I think they're probably not in that neural tube closure category.
Okay, I have another question from Andrea Gilbert. Fantastic talk. How good is the prenatal testing for neural tube defects? And is the testing sensitivity different for different types of neural tube defects?
Yeah, so if it's an open neural tube defect, meaning there's CSF that is in continuity with the amniotic fluid, then the triple screen is excellent with a detection rate of probably over 90%, at least in the 80s. When you combine that with ultrasound, it's really, really good. The problem is when you have these closed neural tube defects, because the triple screen is actually much poorer at detecting. It does detect some of them. It's actually not even clear how, but it's probably because there's some degeneration of brain and those proteins leak out. And so it's probably closer to the 30 to 40%. There, the ultrasound adds quite a bit of value. And so at this time, it's still dependent on what type of defect it is. And if it's open, then you've got a very good chance with the triple screen alone. But with all of them, the combination of a triple screen with ultrasound is really the best way to detect these. Or now people, some people go to MRI if they have any concerns or they're at high risk, and that even has better resolution.
Okay, I have another question from, I cannot see the name, but it says, are glial heterotopias in the paraspinal region associated with neural tube defects, or are those independent?
Yeah, so glial heterotopia are, I think what you're referring to is the kind of neuroglial heterotopia that you can see in these paraspinal and even within the meninges or outside the meninges. You see those with a number of different malformations. I actually find those to be a little bit hard to give specificity. You certainly see them with neural tube closure defects, but I've seen them with a variety of other things. I've seen them with holoprosencephalies. I've seen them with some diffuse polymicrogyrias that have some posterior fossa defects. So I don't put a lot of faith in the specificity of that.
Okay, and I think we have time for one more question. This is from Marwa Abdul Kader. How can you differentiate between a spinal cord lipoma and lipomyelomeningocele?
Yeah, so this gets into some of the variations with the tethered cord. And the tethered cord can be a neural tube closure defect, and you can have lipomatous tissue that is differentiated mesoderm, abnormally differentiated mesoderm in that space that occurs with the abnormal signaling that occurs during the failure of that neural tube closure defect. The lipomyelomeningocele is, in my opinion, kind of a on that spectrum of being a more severe. Remember, I showed that defect of the genes, and then you get kind of the mild and then the more severe. The lipomyelomeningocele and the spinal cord lipoma are all in that spectrum. The tethered cord by itself in my opinion, doesn't have a lipoma associated with it. That is when you have a mesenchymal defect. And actually, Miguel Marin Padilla, when he thought about neural tube closure defects and wrote quite a bit about it, he focused on the mesoderm being the primary problem. And so it's a failure of the signaling and differentiation of that mesoderm giving you the lipoma. It's when you don't have it that you have these the single tethered, really it's the phylum terminalis that is, in my opinion, different than the neural tube defects when we talk about these myelomeningoceles and the lipomyelomeningocele and the lipomas. So that's how I think about it. Again, there really isn't data to support this. It's just based on the kind of biology that I think about it this way.
Thank you, Dr. Golden. Thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again, Dr. Golden, for an excellent presentation. This concludes the session for today.
Thank you all.
Thank you. Bye. Bye-bye, everybody.